The recent outbreak of Ebola in the neighboring Uganda confirms our vulnerability to re-emerging infectious diseases as a continent. Having at least 10 outbreaks, 4 of which were of the Sudan strain, Uganda managed to break its transmission chains, declaring it free of Ebola disease. My name is Gloria Milimu, and on this episode of Health Watch, we take a look at lessons learned from that outbreak that will inform future risk management.
Being registered no new Ebola case despite sustained intense surveillance both at the epicenter districts and nationally. I now confirm that all transmission chains have been fully interrupted and take this opportunity to declare that the outbreak is over and Uganda is now free of active Ebola transmission.
The declaration that brought an end to a nearly 4-month Ebola outbreak that ravaged most parts of the landlocked country, killing at least 55 people out of the 143 confirmed cases. The clean bill of health followed the country's completion of 42 days without active transmission, representing 2 incubation periods of the virus. This was not the first time Uganda was battling the severe disease with high mortality risk. It had yet again been confronted with the Sudan Ebola virus strain that has no proven vaccine. Even so, the country managed to turn the tide on the disease despite having to confront the new public health threat that lurked among its residents in Mubende district, which became the epicenter of the outbreak before spreading to other districts, including its capital, Kampala.
By the time we reacted, about less than 10 had died in the community. But as you know, also community perceptions, you can't stop people from going where they want. Some of these community deaths, we report them as community deaths, but some of them actually go to the private facilities and others go to the traditional healers.
Obviously, Kampala being the capital city of Uganda with a significantly large population, densely populated, high amounts of mobility among that population. And so there was a pretty big concern that once active transmission started in Kampala, and there were 17 cases that were ultimately detected in Kampala, that once that started, it would be very difficult to contain. And indeed, what we saw in the weeks following is that there were sporadic cases that originated from Kampala and then were detected after having moved to other districts, most notably Masaka and Jinja.
Of the 6 previous outbreaks Uganda has recorded, 4 of them were Sudan strain. The country is said to have adopted new strategies that helped curtail the spread of the disease on top of the already existing knowledge that helped fight its previous outbreaks.
With this particular strain that we have just recently dealt with in Uganda, it was the Sudan strain of the virus. What that meant is that we did not have some of the tools that we normally would have at our disposal to respond to it, most notably vaccines and treatments. So in previous outbreaks, such as the one that we had in DRC between 2018 and 2020, you saw inability to conduct clinical trials and to be able to then apply experimental vaccines and treatments. And the research that came out of that meant that we were able to have those tools at our disposal for that particular strain of the virus, which was the Zaire strain of Ebola virus disease.
Movement restrictions in Mubende and Kasanga districts in an attempt to stop geographical spread were imposed, a move experts attributed to the reduction of new cases.
It is entirely possible that those measures did at least help in some way prohibit the spread of the outbreak. Now, that being said, this particular outbreak of Uganda was the largest the country has experienced in terms of geographical spread. So this particular outbreak spread to 9 different districts throughout the country, and that was a point that we certainly had concern over as we were responding and supporting the Ministry of Health in this.
I believe that Uganda did something well when it comes to combating the disease. For example, we remember, to those that have been following the international story of the outbreak of Ebola in Uganda, we remember that the president instituted a lockdown in Mubende and Kasanda. Movement was cut off. No one was allowed to go into Mubende or come out of Mubende. Even the school goers, those that were schooling from other districts besides Mubende or Kasanda, they were organized in one lot to be taken back safely. Government instituted a lockdown that was doubled. For example, when the 21 days first elapsed, they were added 21 days until the 17th of December when the lockdown concluded. The lockdown worked well, but there were some gaps. For example, when it comes to transportation of school learners, government just came out abrupt to stop every kind of movement. And there are learners that actually reached late to their examination centers and they missed exams because of this lockdown. Some, to the stories that we captured, got imprisoned because of curfew. And I remember a case, there were some Red Cross members that were hoping in the mobilization of the communities. They were also arrested.
Experts say the main drivers of transmission were household infection and community practices that did not adhere to public health protocols when it came to managing the symptoms and also handling of bodies. To counter this, the country is said to have invested heavily in sensitization of the community and managed to dispel any misinformation surrounding the disease, among other measures that cut back the numbers of new infections.
Another very important aspect of this so-called community engagement is also the capacity to listen to and understand what communities are feeling about the overall response. How do they perceive things? And how can we best apply those perspectives into our operational response? So whether that means putting up a healthcare facility, specifically an Ebola treatment unit, in one location versus another, that might be more acceptable to the community.
What will work for us as a country is the communication from development partners together with the government of Uganda through the Ministry of Health. People really came up on board. They did different campaigns to educate the masses, also community barazas for them to spread the information in the communities. To the communities of Mubende, Chegegwa, Kasanda, where I was, ministry had teams on ground, but also development partners really worked well to see that they spread the community, they spread the gospel of what exactly the disease is all about, what exactly they need to do when they get the disease or when they suspect that their neighbor or anyone could have the disease. Risk communication was key among the things that helped the government to fight the outbreak. In just 69 days, that is the record Uganda has recorded now, 69 days, an outbreak that has recorded over 142 cases was really won. Also adding on the other 42 days that are recommended by WHO. In 69 days, the government had already seen where it is heading. So risk communication was key among them, but also the teams coming together to allocate funds. For example, the $6 million that Uganda invested in the fight against the Ebola outbreak was meant for COVID-19, but they did see that, you know what, Ebola is here, COVID is not that severe. We need to see of how we allocate sources. So they had to come up together with the development partners also having contributed a lot of the money in the fight of the outbreak.
Similarly, what also worked for the country that other countries in the region can borrow from is decentralization of Ebola management services, as explained by Rizzo.
Globally, what we try to do is something that we refer to as a decentralized approach. So that means rather than putting up a big Ebola treatment units in one location and having patients come from far distances to that treatment unit. We rather try to bring the treatment units and the healthcare as close to the people and to the populations as possible. And that typically means the communities are more likely to be on board and accepting of what Ebola is and help tackle some of the rumors or the fears that might be surrounding Ebola.
Uganda has two main labs, one in Luzia and then the other in Entebbe, that is the Uganda Virus Research Institute, that has been really working well in the prevention of outbreaks and also working well in the surveillance system. But also the introduction of these surveillance labs, mobile surveillance labs in different communities across the country. I do believe that maybe in one way or the other, they will help the country to better its surveillance systems, because the government will not need to transfer or to transport any tests that are done in Mubende to Entebbe or to Luzia. The tests will be done in Mubende or any other district. So I believe this is the right move and the right direction when they introduce these surveillance mobile labs in different communities.
The global community is learning a lot from this success. This success is not only of Uganda, it's a global success, and the global health community will learn and follow Uganda so that Ebola is not as scary, Ebola is not as devastating as we used to know it.
There are 6 known Ebola viruses, 4 of which can cause human disease. These are Sudan, Zaire, Bundibugyo, and Thai forest viruses. Whereas there is no known effective vaccine against the Sudan strain, researchers say there are only 20 Sudan strain of the Ebola virus research studies, majority of which have been implemented in the United States of America and only 1 in Uganda.
This particular strain that we have just recently dealt with in Uganda, it was the Sudan strain of the virus. What that meant is that we did not have some of the tools that we normally would have at our disposal to respond to it, most notably vaccines and treatments. So in previous outbreaks, such as the one that we had in DRC between 2018 and 2020, you saw inability to conduct clinical trials and to be able to then apply experimental vaccines and treatments. And the research that came out of that meant that we were able to have those tools at our disposal for that particular strain of the virus, which was the Zaire strain of Ebola virus disease.
9 of these studies are on therapeutics, 8 others touch on diagnostics, 1 on health, and another on social science, a disparity that highlights the need for investment to help come up with an effective vaccine and therapeutic strategies to help combat future outbreaks.
Investing in capacity building and training for frontline healthcare workers. So making sure that nurses, doctors, hygienists, nurse assistants, all of the healthcare staff that you would typically encounter at both public and private facilities have the capacity and the knowledge base to know how to respond, how to detect Ebola, and how to engage within the existing healthcare system. That's tremendously important. In addition, it's important to ensure that these healthcare facilities have the supplies that they need, whether those are hygiene supplies or supplies that can assist in infection prevention and control. All of these things can ensure that facilities are better equipped in the event Ebola or a similar infectious disease outbreak occurs in the country. So those are 2 of the biggest areas I would say is investing in research and then training and capacity building.
In terms of vaccine development, AstraZeneca and Oxford University's Jenner Institute are said to have a vaccine that can induce an immune response in both Zaire and Sudan strains currently in phase 1 trials. Currently, there are only 2 licensed Ebola vaccines. The Zaire strain vaccine is not effective against the Sudan strain, though a Johnson & Johnson vaccine is being tested against it. Gloria Milimu, KTN News.